Hi, I'm Melanie from Riding to Health, and I am here to talk to you today about the anatomy of the knee. Now, I have been lent an actual knee joint model by a local doctor, so thank you, that doctor, so I can actually explain it to you. So I'm going to start off with what is what. So this is the front of your knee. This is the tibia and the fibula. These are the two bones in your lower leg. This is the femur. This is your thigh bone. And here, behind there, that is your kneecap. And it's held in place by the patella tendon. Then, we've got a whole lot of other ligaments that stabilize the knee joint and hold the top and the bottom of your leg together. So you've got the medial and lateral collateral ligaments here, and they hold your knee on the sides. And then if we bend this knee joint just slightly and lift the kneecap away a little bit, you can see deep inside there, right in there, these crisscross pieces right in the middle of that knee joint, they are the anterior and posterior cruciate ligaments. Now they hold your top and your lower leg together. And they're the ones that tend to tear when a footballer or a rugby player has an accident on the field where they go one way and their foot goes a different way in the direction that your knee does not normally bend. Now, if we go back to this knee joint, and let me just move the kneecap out of place. So this is the anterior cruciate ligament here. And in my knee, this is what I tore back in the 90s. Now, in my knee, this ligament is now a graft, and it was grafted from the patella tendon. So they took a slice out of here and they've screwed it in place down here. So there's a bolt in my leg up here, and there's another bolt in my leg down here that holds that in place. That stabilizes your leg. And when I didn't have the anterior cruciate ligament, I would often turn around, you know, you twist and you leave your foot in place, but you turn. If I was to do that without the anterior cruciate ligament, I would end up on the ground because it would totally destabilize the joint. It didn't used to hurt, it just used to look really stupid. So that's the anterior cruciate ligament. And then behind it, around the back, you've got the posterior cruciate ligament. And they cross over like this, and they hold your skeleton together with the help of these two here. These are the medial and lateral collateral ligaments. So this is the front of your knee, and this is the back of your knee. So you can just see the posterior cruciate ligament there in the back of your knee. This is the top of the femur, this is the top of the tibia. Then there's one more piece I need to show you. We've got the medial meniscus. Now this is the piece right here that's in between. Let me see if I can just move this kneecap in a minute and move it, open it up. You see the disc here? This disc is the medial meniscus. Now what it does is it protects these two bones from touching each other. Now in somebody who's got a damaged knee, through age, arthritis, that sort of thing, that tends to need a knee replacement, the meniscus is what usually has worn away, and so the two bones are touching. Now there is two types of cartilage in a knee. Everything gets called cartilage, but it's actually not. So the end of your bone has got cartilage on it. This model, it doesn't show it, but you know, like a dog bone that's got a shiny end on it. Well, the end of the bone has got cartilage on it, and it protects the bone from chipping. And then you've got the medial meniscus, which is this piece in here. And this also often gets called cartilage, but it's actually not. And this is the piece that protects the top and the bottom of your leg from knocking together. Now I'll show you what happens when the knee joint bends and flexes. So here's your knee, and the patella tendon stretches as the knee bends, and the gap opens here, and the anterior and posterior cruciate ligaments are under tension, and they're holding you stable. So that's what happens when the knee bends. You've also got the stability of these two on the sides, which tend to have less likelihood of injury than these two in the middle. Now, when they replace a knee, There is a lot of different ways that they can do that. Now, they tend to prefer to replace as little as possible because you need to retain as much of your own bone as you can. So we'll start with a unicompartmental knee replacement. So what they do with a unicompartmental knee replacement is they will replace one side of this bone. So they would replace either this end, this bit here, or this bit, or the same on the top, one side or the other. So it's like a quarter of a knee replacement. What they do is they take the bone out, the diseased bone, and they replace it with a metal cap that works instead. Now clearly there is nothing that has the same wear and durability as the human tissue, so that is why knees wear out. Then if they're going to do a partial knee replacement, is what they normally call it, this is what my dad had done, then they will replace either the top or the bottom. So they'll either replace the end of the femur with a metal replacement, or they'll replace the top of the tibia with a metal cap replacement. And that gets screwed into place, and it's usually one or the other, and the rest stays intact. If they're going to do a full knee replacement, there's still a couple of ways they can do that. Now, I just learnt this yesterday. They can keep one of these ligaments. So if they're going to replace a full knee, they can put a full knee joint in and retain the posterior cruciate ligament. They don't tend to retain the anterior cruciate ligament. What they tend to do is take it out. So when they do my knee replacement, they will take the anterior cruciate ligament graft that is in there out. They'll take the two screws out, and then the complete knee prosthesis, which goes in instead, will have a plastic cap in here in place of the medial meniscus. A plastic cap will go in there, or should I say cushion. The plastic is taking place of the medial meniscus, which is the cushion between the top and the bottom bones, between the cushion between the femur and the tibia. So that is replaced with plastic. Now, what they do with the rest of it is a metal plate goes on the top of the tibia. So it's a flat metal plate, and then if you imagine this whole front up to about here gets replaced, and it's curved, and there's two sections to this bone. They're called condyles, and if it's a full knee, they'll replace both sides of that with metal. There'll be a plastic cushion in place of this meniscus here, and then there'll be a metal plate on the top of the tibia. Sometimes they try not to. Sometimes they will also replace the kneecap. Now, in my knee, they're going to try to not replace the kneecap if they can help it. The reason is because my patella tendon has already been weakened when it had a graft taken from it for the anterior cruciate ligament operation that I had way back in the 90s. So that weakens this patella tendon, and they tend not to want to mess with it if it's likely to be slightly weakened. If there is a really big problem when he opens up my knee and has a wee look, he said he might put a plastic button, I think he said, in there, but they're going to try to not replace that. So a complete knee would be the femur replaced, a metal cap on the top of the tibia, a plastic cushion in here in replacement of the medial meniscus, and possibly a prosthetic kneecap as well. Now, the plastic button, from what I can gather, goes on the back of the kneecap, and the kneecap stays in place, and that I'm assuming is to put against where the friction points would be, and to replace the damaged back of the kneecap with a new piece, and the rest of the kneecap stays in place. But like I say, they try to not replace as any pieces if they can possibly help it. Now the reason that I need a full knee replacement is because I have a graft in place of my anterior cruciate ligament. And that means that my knee is not as stable as a normal knee. So a normal knee, you can't usually move it too much in this direction, and you can't normally move it too much in that direction either, because the anterior and posterior cruciate ligaments hold it in place there. Whereas mine is not a real ligament, it's a graft. And that makes mine more unstable in this direction. There's a lot of movement in my knee in this direction, which there's not supposed to be. Now, if you can imagine that all these pieces that are touching are all metal, and my knee is going to do this a lot, what's going to happen? It's going to wear out really fast. So that's why they don't think a partial knee replacement is going to work, because the ACL is not in place, so they can't do it. So the full knee replacement replaces the ACL with the prosthesis that goes in. It takes the place of it, and from what I can see on the images, there's a ridge in the middle, and that helps to stabilize it this way and helps to stabilize it that way when they put the metal in place. Now, what happens over time? It's going to wear out, and it's a bit like anything. It wears out a bit faster than your actual joints. So my knee, when they replace it, it's not going to be like that forever, because the metal is going to wear out faster than my bone, because my bones were supposed to last me till I die. So that's why a knee needs to be replaced. Depends how I behave and how well I look after it as to how often a knee needs to be replaced. They say possibly 20 years if you're really lucky. Usually it's 10 to 15 years. Then if you can just imagine this, because here's your knee, picture this. A knee replacement the second time round, you're going to have to mess around a lot more, because you're taking all of the metal out to put more in. So each time the bone gets disturbed, it's going to make it less effective. So the first knee is going to be fab, I hope. But after that, each subsequent knee that I need to have in subsequent years, and this will be a slippery slope till I die, they will not work as well as the first one, and each subsequent knee will be slightly less effective. So I'm just going to show you a moving knee. So we're going to start at the front. This is the left leg, and we're going to move it backwards and forwards like this. So that's how the joint moves. This is obviously attached further up, and my model doesn't go that far. And then we're going to turn it around, and I'll show you how it moves this way. So if you look at how much that kneecap moves inside there, look at how much that moves. That's why they would put a plastic cap on the back of the kneecap if the kneecap was a problem, but they'd leave the kneecap in place because it's embedded within the patellar tendon. Now, look at the rest of the knee anatomy when it moves. So all of these ligaments here are working, and so is this one in here. The anterior and posterior cruciate ligaments are all working to keep your leg stable. So what they do is they stabilize it this way. That's these two, and the two locked inside there, there's one, and the other one's be in there. Those two stabilize it this way. Now in my leg, I've got a graft in place, so one of those ligaments is not as good as the other one because it's not real. So my leg moves a bit too much in this direction. So if you can imagine that this is a prosthetic knee and there's metal here in place of bone, and it's going to move around a bit too much, what's going to happen? Then it's going to wear. That metal is going to wear, and the knee joint will wear out. Now the first time they put a knee in place, you can imagine it's a pretty dramatic operation. However, it works quite well, and a lot of people have them. But the next time they put a knee in, just imagine what they have to do. They've got to take all of that metal out and screw a whole load more in. Each time they disturb the bone, it is less effective than the first time. So if you're really lucky and you really behave yourself, apparently a knee can last 20 years. The normal, if you look at it up on the internet, the normal shelf life for a knee is about 10 to 15 years. So let's see, the age that I am right now, you might expect me, if I'm going to live to 80, to have 3 more knees. That's not good if they only last 10 years. So the third one will be a slightly rubbish compared to the next two. So I'm going to have to behave myself. So a quick re-summary now. The colours on this model are a little bit deceptive, but ligaments attach your skeleton together. Without them, whoopsie, your joints become unstable. So ligaments attach bone to bone. Tendons attach muscle to bone. So that's why this is not attached at the top, because it would run into your quad muscle somewhere. Okay, so that's the difference between tendons and ligaments. Ligaments stabilize your joints by attaching your skeleton together. Now, I'm not sure if I can show you this, but I just want to show you how the anterior and posterior cruciate ligaments work together. So if you look at where this one attaches, it attaches at the front here, and it goes right round. I'm just going to show you here. It comes from the front and it goes round into there, okay? And then the posterior one does the opposite. So we've got, let's see, there's the anterior cruciate ligament there, and they cross over back here. I don't know if you can see that. They cross over back here, and it's the crossover action is what stabilizes the knee joint, and that's why the anterior and posterior cruciate ligament work together and are both really important. Now, when I snapped mine, I went like that. So my leg bent in a direction it's not supposed to. So if you can imagine, you can see that what's going to happen there, can't you? When it snaps, if it snaps and it's in the middle there, twang, like an elastic band, it's going to hit a whole load of stuff before it settles. And that possibly could be why medial meniscus damage is connected to anterior posterior cruciate ligament damage, because they're so close together, and it would likely ricochet off a couple of surfaces when it snaps. So I just want to thank the lovely doctor who lent me this knee, because it's been a great thing to be able to show you how the knee joint works with an actual model, and they're not cheap to come by. So thank you, that doctor, for lending me your knee. I'm hoping that has been of some help and maybe some interest to you. If you've got any questions, I'm happy to take questions. If there's anything you would like to know, fire it back at me, because if you're going to ask me a question about a joint, the knee joint is the best one to ask me, because I know all sorts of stuff about the knee joint because of all the trouble that I have had with knees over the years. I have done a lot of research, so I know the model of the knee better than any other joint in your body.